Hello, welcome to the Shropshire CCG board meeting. If you'd like to take a seat, we're due to begin in just under 1 minute. Welcome to the CCG meeting. I'd just first of all like to say or point out, you may not have noticed, the meeting is being live streamed, so that was put on the information was on the website to notify anyone who's attending, so hopefully everyone's comfortable with that. We've got some apologies today. We've got apologies from Jessica Sokoloff and Steve James. We then need... and Nikki Wilde. Next item is the declarations of interest. Obviously, they're declared on the website. But if we can go around the table and declare any declarations of interest that in relation to papers today, and any declarations that aren't currently on the website. If we can start with Jonathan.
Yes, no interest to declare, Chair.
No interest to declare.
I have a relative who works at SAF.
No interest.
No interest for me, thank you.
No interest, thank you.
Nor for me, thank you.
I'm a partner at Ponsbury Medical Practice, and also got a new declaration of interest. My wife, Dr. Jane Povey, has been appointed as the Medical Director to the Community Trust, and that was announced this week. So she's not yet in post, but she will be in post very soon.
I have no interest to declare.
The old joke's always the best jokes.
I'm a GP at Bishop's Castle. My husband works as a locum for Shop Doc doing GP streaming at Telford, and is currently in dispute with SAF and West Midlands Ambulance Service.
I'm managing partner at a practice in Oswestry, and my wife is an exec on Telford and Wrekin board.
No interests.
I'm a GP at Belvedere Medical Practice partner, member of the Darwin Group, and I'm a GP appraiser for NHS England.
I'm an employee of Shropshire Council, and I'm also Deputy President of the Royal College of Nursing.
I've got no interest to declare.
Nothing to declare for me.
My wife is a member of staff at SAF.
Nothing to declare from me.
Nothing.
I've got some brief introductory comments to make. One is just to highlight today that it's World Mental Health Day, and that's to raise awareness of mental health and to highlight mental health, and they're focusing particularly around young people. So obviously there's some key issues on our board paper today around the CAM service and 0 to 25. It's also Baby Loss Awareness Week, and obviously for Shropshire and Telford and Wrekin and SAF that carries some significance, and it is again that's an awareness raising week. And it's the Hospice Care Week, and obviously in Shropshire we're very fortunate to have the Severn Hospice that provides care to our patients both at home and in hospice across sort of Shropshire, Telford and Wrekin and Powys. Since the last meeting, obviously something fairly significant happened in that Dr. Freeman, to my right, has announced his intention to retire. Simon might want to say a few brief words, but basically he's been with us for 2 years, our accountable officer, and will be working the next 6 months to try and help keep moving the CCG forward. He came in at a time of relative instability. We'd gone from a stable organisation to having had 2 interim AOs in very quick succession, and Simon came in and has steadied the ship and moved us forward, and we are dealing with some of the challenges that are in front of us. And I would like to thank Simon for his current work and obviously for the work he's going to give us over the next 6 months. But I don't know if you'd like to briefly make some comments, Simon.
Just to say thank you to the chair. It's been a very enjoyable experience. It's been a really tough job, and the next 6 months are going to be difficult as well. But hopefully the organisation's in a much better position than it was a couple of years ago, and that's down to, I think, the executive team here, the clinical team and the non-execs. So Sorry. I think we've moved the CCG forward quite a bit from where it was. There's still a fair way to go, and that really is testament to everybody around this table. It's a testament to the non-execs, to the exec team, and to the clinicians here. So hopefully it's in a better position going forward, and I'm sure the CCG will be successful in recruiting a high-quality replacement.
Thank you for that. And obviously we have a few more board meetings prior to Simon's departure at the end of March. Moving on from my introductory comments, we'll move on to check the minutes of the previous meeting for any factual corrections and accuracy. So if we look at those, if we look first at pages 1 through to 10. And then 10 through to 15. And then 15 through to the end, which is page 22. If there's no comments or corrections, we'll accept those as a record of the meeting. Thank you. And then we move on to the matters arising. First matter arising is an action for Dr. Davis with regards to keeping Ms. Jill George appraised of the current situation around the financial savings and investment with phase 2 of the Care Close to Home transformation programme.
Yeah, and that work is ongoing. I would hope that we will be in a position to give Jill some information in time for the next board meeting.
Okay. The next 3 actions, 2 are on the agenda and 1 self-explanatory. Moving on to the action 222, which is Dr. Davis to establish a performance data for annual health checks for children and young people was available, and feedback to Mrs. Clark.
To confirm that the performance data does include anyone aged 14 and over with learning disabilities. There's no data collated for children under the age of 14, but that's the data that is available.
Okay. The next action is a change to the contract report. It's been actioned.
Yeah, we've included that in this month's report.
Move on to 224. Ms. Clark to present the outcome of the deep dive into BU Emotional Health and Wellbeing Service to the October Governing Body Board meeting. That's quiet on today, isn't it?
Yeah, sorry?
It's on today.
Yes.
Yes, yeah. Dr. Davis to raise concerns with the governing body members in relation to SATH's appointment system at the next planned working group. Is there any feedback from that?
Yes, we raised that at September's meeting, and their Assistant Chief Operating Officer for Scheduled Care is bringing an update back to October's meeting.
The next action probably becomes more pertinent with more recent sort of SIs that have come to light around the IT, but Dr. Davis to check
yes,
if
I can
risks
confirm there are a
associated with
number
IT.
of IT-related items on SATH's risk register, but we have asked for it to be refreshed in light of recent issues to make sure the risks adequately reflect the current issues that have been identified.
And in terms of the current risks, which were regards to the A&E letters, are we further forward with a solution to those? Has SATH got a plan?
We have a plan for one of the issues, and we're working that through at the moment. That's relating to where there was the IT glitch, and we can generate the letters manually, and then how those are communicated and shared. We're working with primary care colleagues. Had some feedback, helpful feedback from our South locality last Thursday, and I fed that back to the Deputy Chief Operating Officer of the hospital, and we're working through that. To the best of my knowledge at the moment, the second issue with regard to the closure of records by medical staff, they don't have a solution for that yet.
Okay, no, thank you. The next action was for Nicky Wild and yourself to check some figures and report relating to patient access to patients accessing service when the GP practice was closed.
Yep, we've asked for that. This was around checking it was around the marginal cover. That's what we'd asked for. So we've made sure that in terms of the data being reported by NHS 111, we are tracking that, and I can confirm in terms of the latest data that we've seen no there's no material increase during that marginal time into 111, but we will keep it under review.
Okay, thank you. Simon, the next action was to arrange a meeting with myself, yourself, Claire Skidmore and William Hutton and Sam Tilley to... That's fine. I do have to read some of them as well. But also, okay, thank you very much for that. Next item is for Simon, Claire, myself, Will Hutton and Sam to meet to reflect the issues raised in the Audit Committee report. Simon?
I think we're in the process of arranging a date for that.
Okay, thank you. Next one was for Dawn Clark to meet with Lisa Roberts in relation to a recent patient experience. Is that?
Yes, senior nurse in my team met with Mrs Roberts when I was on leave, and they're pursuing the complaint.
The next action was for Nikki Wilde to raise, but she's off ill, so I was wondering if someone else is going to pick that up about an update on the mobilisation of the out-of-hours service provided by Queen's Trust and Shropshire Gale.
I can pick that up, Julian, thank you. So the service went live on the 1st of October, and so it's fully operational now. We continue with an implementation phase for 6 months that will take into account any concerns that have been raised by the governing body. So we'll bring back a report to the governing body in due course.
Okay, thank you. The next item is on the agenda is the first item, which is the SAF quality review update, which Dawn's going to present. That was just in the minutes. Sorry, Simon was just showing me the Appendix 1, but that was an AOB at the last board meeting. Dawn.
The main report.
Yes, yeah.
Thank you. So the governing body will have read the report, but because of the importance and the specific timelines, thought it was important to spend a little time on this report today. So it does provide a summary of the events of the last 12 months, where we've raised concerns of potential harm to patients, predominantly as a result of workforce issues, and the analysis of serious incidents with within the SAF emergency A&E departments. In July 2017, both chief officers of Shropshire and Telford CCGs wrote to NHS England requesting a risk review, and this was a result of a series of concerns that were of significant materiality and which together added up to a significant clinical risk of harm to patients. Those areas included ophthalmology, maternity, patient follow-up, and delayed diagnosis of optimal care. NHS England instigated a risk review as part of its quality surveillance functions, and this was the third SAF risk review meeting, and concerns were raised by the CCGs about previous improvement plans not being sustained by the Trust. At the time, the Trust had been on enhanced surveillance with the Quality Surveillance Group under NHS England since before 2016. The risk review took into consideration the work that had been done by the Trust and the evidence of work on learning from incidents, workforce recruitment issues, recruitment planning events. But it was agreed that a workforce education plan would be considered, and a planning event took place in October, and that was to look at some of the significant workforce issues that have been highlighted, and trying to find local solutions supported by Health Education England. At the time, the Care Quality Commission reported that the service was well led, and the enhanced surveillance of the Trust was maintained by the NHS England Quality Surveillance Group. However, despite the actions being taken, concerns continued, and in March 2018, as a result of some further serious incidents being reported in the A&E department, the CCG accountable officers wrote to the SAF Chief Executive stating that the Trust services under the Spotlight paper had noted further fragility of services. Referred back to the risk review findings of the 40% gap in junior doctors, and the department functioning on the 5 emergency department consultants, whereas the Royal College would be recommending up to 20. The CCGs acknowledged the great progress that had been made, but did request a meeting with the Trust and a robust recovery action plan. The letter acknowledged the potential to request NHS England via the NHS England Quality Surveillance Group process to progress to a further risk review and potentially a risk summit if that was indicated. Since early April, the CCG has also raised concerns as regards patient outcomes within the A&E departments at SAF, where the trust root cause analysis in a number of cases appeared to indicate that staffing shortages may be impacting on patient safety. And those incidents included evidence of poor sepsis management and suboptimal observations in some instances. A tripartite meeting took place on the 30th of May, where discussion of these serious incidents was held, and the Trust responded with a wide-ranging report on safety, which raised other concerns, but which did not specifically detail the root cause analysis on the serious incidents raised. And we did not receive a mathematic analysis as requested. As a result of the tripartite meeting and subsequent report received from SAF, the CCGs and the Trust agreed to request an informal risk review via NHS England. Prior to the meeting taking place, the CCG advised that the Shropshire Local Safeguarding Board, Independent Chair, and the CQC Inspection Manager of the request for the review. And the risk review and its attendant actions took place on the 14th of August. Specific actions arising from the review were that the Trust and the CCGs to review the Safe Today metrics, which had been established on the 1st of August, and agree a new set of data for daily assurance of the A&E departments. The Trust with the CCG, supported by NHS England and NHS Improvement, to undertake a rapid options appraisal and actions in line with the timeline set out in the presentation from SAF in respect of business continuity from a patient safety perspective. So since the 1st of August, those Safe Today calls have continued. The SAF executive clinical leads in terms of safety for the Safe Today calls request from the SAF clinical executives, their assurance in terms of safety for the previous 24 hours, the point of time of the call, whether it was safe, and in terms of staffing capacity and capability for the forthcoming 24 hours. During the immediate period after the risk review, CQC undertook and announced visits to the Trust in a number of areas, including maternity and A&E. The initial letter to the Trust following these inspections was received by the CCG on the 29th of August, and those contents have been covered widely in the health press. The CCG sought confirmation from the CQC whether any safeguarding referrals had been made, and CQC confirmed that none had been. But the CCG also requested our Head of Safeguarding to undertake further review, and the Independent Chair for the Safeguarding Boards in Shropshire has also invited SAF to present any outcomes of concerns raised, and they will be taking place shortly. So following the risk review on the 14th of August, the CCGs sought advice from NHS England about ongoing concerns with respect to patient safety, and formally wrote to NHS Improvement on the 30th of August to urgently consider the next steps and whether Trust Business Continuity Plan should be enacted immediately. Within the CCG letter, it was noted that the planned options appraisal meeting on 28th of August relating to the business continuity plan did not give an indication at the time as to which of the options offered increased assurance of safe care to patients. So on the 6th of September 2018, NHS England held a formal regional risk summit to consider the next steps in the SAF business continuity plan. And also on the 6th of September, CQC issued the first of the 3 Section 31 letters regarding safety concerns and their intention to issue enforcement actions against the Trust in A&E and maternity. These letters have been widely covered in the health press. The weekly returns required by the CQC against these letters have been received by the CCGs. The CCG is advised by the CQC that the recent Care Quality Commission inspection is now complete, so report writing is underway, and that will be subject to a robust timeline of quality assurance, including a period of factual accuracy checks with the Trust. CQC has taken urgent enforcement action where deemed necessary, and this remains subject to legal process. Details of the action taken were shared with the relevant bodies in accordance with the Health and Social Care Act, and as a mechanism to secure support for immediate improvements. And that final report will, of course, refer to any enforcement action taken. Further on 13th of September, NHS Improvement and NHS England medical directors jointly chaired a regional risk summit with West Midlands and Welsh commissioners and providers to consider the impact and necessary arrangements required should the business continuity plan be enacted. And on 13th of September, we also received the West Midlands Quality Review Service, on 13th December, at the same time, the West Midlands Quality Review Service was also undertaking a review of the care of critically ill and critically injured children, alongside the West Midlands Paediatric Critical Care Network. Immediate risks related to medical staffing availability and competencies, and the Trust has responded with an action plan. On 27th of September, the SATH Trust Board agreed on the basis of a detailed business continuity option appraisal to suspend overnight A&E services at the Princess Royal Hospital in Telford due to medical and nursing staffing issues in the emergency departments. And preparation for PRH overnight closure continues in collaboration with the Trust and other providers and commissioners. Last week, the CCG were advised, or its previous week, was advised of the Regulation 28 coroner letter issued, which highlighted medical staffing issues and sepsis management as a significant concern. And the CCG has received the Trust's response to that. In the meantime, the CCG is seeking to commission an external review of serious incident identification, management and learning at the Trust, as well as our own processes. And in the next fortnight, the CCG will enact a programme sequence of planned and unplanned visits with clear purpose, documented outcome and assessment. And those visits will include staffing, pre-A&E corridor management observations, and that would include the early warning scores, the environment and compliance with policy and process, such as cardiotography, C2G management. As a result of discussions with NHS England, a monthly quality improvement executive group with NHS England and NHS Improvement with the Trust and CCGs has been convened, and that begins next week. This will include A&E maternity services and will be a minimum of 6 months, ready to focus on service improvement plans. Those terms of reference to be considered at the meeting next week, and membership will include the 2 CCG clinical chairs, chief officers and other CCG clinicians, and the 2 CCG executive nurses. A number of actions are underway and planned, and those include an assessment of both the CQC Section 31 ED and maternity submissions and how these fit into the CCG assessments of safety, and that process has been undertaken currently to be completed within the next couple of weeks. An update report on serious incidents will be considered at the Governing Body Part 2 meeting today, and that has been undertaken. The Safe Today methodology and monthly outcome measures are currently being reconsidered. We're doing gap analysis on what we're receiving and what we need to receive, and the Trust is working with us on that. There's a proposal to carry out a review of all the serious incidents that will take place. The CCG will enact a programme sequence of planned and unplanned visits, as stated previously. And then a monthly quality improvement executive group with NHS England and NHS Improvement has been convened, as stated previously as well. So apologies for taking such a long time going through that, but I think it was important to hear the work that is underway but also planned going forward. Thank you.
Okay, thank you for that, Dawn, for that comprehensive assessment. Just to clarify, those we have obviously been bringing that regularly back to our board meetings, so most of these entries and information can be found in previous board meetings, is that?
Yes, they can, and we've done a chronology of all of the Quality Committee papers, the board papers, meetings with the Trust, CQRMs, Quality Risk Management meetings, and reports up to Quality Surveillance Group, and that information is available also.
Thank you. So open it to the board for questions. Finola, sorry.
Thank you, Julian, and thank you for going through that so comprehensively, Dawn. Maybe it feels counterintuitive to still ask this, but although clearly there's a lot of evidence of a lot of work having been done, a lot of things identified and escalated, but are we absolutely satisfied, as I suppose, as a CCG, first of all, that we've done everything that we needed to do to both support SATH, but also to raise the concerns that we had?
Dawn.
As executive nurse, I would say we can always do more. There's more that we can always be doing. Looking back at the chronology, I think we have been raising issues and we have been having appropriate responses from the Trust. We have a plan of action here that we considered and very happy to take suggestions on what further needs to be done. I think as mentioned at last board, the opportunity now with the NHS standard contract come to the end of its 2-year process, we have a real opportunity now to review the local quality schedules to really, with all of our providers, to make sure that we can really get the data that we need. I think some of the problems that we are seeing, that Julie referred to earlier, is the ability of SATH to be able to provide us with data in a meaningful way. So some of the Safe Today indicators, for instance, are very reliant on manual reporting by the Trust, which adds additionally to their the impact on their time. So that is a major risk as far as I can see.
Thank you. Keith?
I'm still not quite clear about the role of the CQC in terms of what information they're going to share with us and at what stage that's going to be shared with us. Do we have an indication of the timeline of that?
I did speak to the lead inspector at CQC before preparing the report to see if we could have any timescales, but the statement was what they wished us to include in this, and they weren't able to give me any timelines at that stage. But we are working closely with them, and Simon had already requested a meeting with them, with the 2 clinical chairs, the 2 chief officers and ourselves as exec nurses, to meet with CQC as soon as possible. We have asked them for that, and we're just waiting for dates back.
Thanks.
Further questions? I've got Deborah and Rod.
Thank you, Dawn. It was a really helpful summary, I think, and these issues have been going on for a long time, so I found it particularly helpful to have it detailed, everything that's happened and everything that's been done. And I found that quite reassuring that it reiterated that we have been flagging our concerns for a long time and doing what we need to do. We do need to think about what we are doing going forward, both in the short, medium and long term, to ensure safety of our patients and population. I think our role really is to hold the providers to account and flag our concerns more widely, because there is a limit to what we can do as a CCG. But I think we do need to be holding SATH to account for some of the actions that we've required, particularly in things like data collection and audit, because those are things we can measure that they're doing. Some of the things seem to be out with their control, particularly around workforce, but there are other things that they can be addressing. And I think we also need to remember that going forward, there are obviously plans to change the way services are provided, and we need to make sure that we can assure ourselves that those services will be safer than the situation we find ourselves in now.
Thank you. We've got Rod and then Finola again.
Thanks, Chair. Again, thank you for the report. It's very helpful. It's with regard to point 27 on the report, which effectively is looking at the discussions that will now occur between NHS England, the executive group, NHSI and the like. I think it's important for local people to understand that they're getting consistent and quality information from all of the bodies that are involved in trying to ensure that SATH is delivering quality services for the local population. I see that the terms of reference will be considered at a meeting on the 16th of October, and want to see within those terms of reference some reporting system that allows us to give confidence to the public that the work that, as you've described, is going on is actually delivering changes to the safety of those services. Have we any indication about what those organisations intend to do to ensure that they will talk to the public as part of this new group?
Simon, do you want to take that?
I'm quite happy to bring that up, Rod, with the group next Tuesday. And I know, Rod, we've spoken about the concerns that exist at the joint HOSC level as well about provision of information that we've discussed and will be taking forward with the Trust.
Thank you.
Finola?
Thank you. I wanted to return to Deborah's point, actually, because I think it's important as a clinician to talk particularly around this piece of work. I sit with Dawn on the clinical quality review meeting and have done for the last few months. And I am very confident or comfortable with the way that we have dealt with SATH, in that it is a very supportive, we've been very supportive in our approach, but very mindful also that things need to be done and we need to hold them to account in terms of the quality of the services patients are getting. I think, as a clinician, I'm particularly cited on things like how the organisation learns from mistakes, because that's something as a clinician that I have to take on board personally, as well as what in the way that I'm accountable to my profession. And I think it is these areas, things like audit and learning from errors in particular, that I think SATH need to demonstrate more fully that they are doing. Certainly with the serious incidents that we've seen come through, it's often the action plan and the enforcement of that, so that it becomes part of the new culture that's developed as a result of a mistake, unforeseen or otherwise, that really demonstrates that an organisation is moving forward. And I also feel in my dealings with the team that there's often issues around how they communicate with us, and possibly there's issues around how we communicate with them that we need to sort of reach out to and address. I think possibly there's also issues with the way they communicate with the population as well sometimes. I'm also mindful of the fact that they are aware too that staff there feel are in a very difficult situation, particularly in ED. But there are issues around how the staff are being treated on occasions, and that they need to be supported, particularly at this very difficult time. And when I say that, I also reach out to the public and those who are in a position to talk about this situation publicly, that we do need to be mindful of the fact that the staff carry on working and doing their very best, and I think we need to be mindful of that. So yes, I feel that we have done everything in terms of escalating our concerns, but we've always done that in a very supportive way.
I've got Dawn.
Thank you, Chair. And I think it is important for the public to be assured that actually the vast majority of the time the services are safe for patients and the public. It's very important. There are large numbers of staff there are working day in, day out, really focused on good, safe patient care. Finola, thank you for what you've just commented on now. I mean, I work predominantly with the Director of Nursing at the Trust. She and her deputy came to our Quality Committee in February to provide an overview of the governance arrangements they have in place for improving serious incident reporting and the learning from incidents. We know that a lot of work has been undertaken, but we do know as well that it takes time to embed a lot of that. And I think we are starting to see those improvements. But clearly, as the Trust has acknowledged, they've got further work to do, and I think we do need to acknowledge and be supportive of them in that, but whilst recognising some of the risks that there are.
Okay, I've got William and then Meredith and then John.
Thank you, Chair. Dawn, through your very helpful and comprehensive timeline, there's a number of points where it appears that SATH have either sort of failed to provide a response or been very slow in providing a response, things like root cause analyses of SIs and so forth. Is there anything more we can do, and maybe I'm looking to the broader executive team contractually, to improve that situation, because getting timely information is key to actually help all of the parties move forward in a timely manner.
John too.
Just comment, I think the report following the tripartite meeting wasn't as we requested, but they did provide quite a comprehensive report on other issues within A&E as well as serious incidents. They didn't answer the question that was posed to them, and that they agreed to provide, so that was disappointing. However, that wouldn't have gone down a contractual route, but absolutely. And I think coming through the quality schedules now, with the contracting team, I think we have a real opportunity now to be absolutely clear about what we expect, and then to raise contract notices if required. And I'm sure Gail will talk more about that. But you know, we prefer to work with them to not to be in that stage. And I think it is about that openness and sharing of information whilst they're embedding new services. But clearly, there are times where we will need to use that contracting route.
Okay, thank you. Meredith.
Thank you very much. Thanks for the report, Dawn. Yes, as every others have said, it was very informative and helpful. Two things struck me. Number one is there's so many people crawling over the organisation. It must be in itself be extremely demoralising and demanding, just supporting all these inspections and investigations and so forth. So that struck me. But secondly, I've seen very little information about the extent to which the organisation is seeking and using the views of the very people that it's serving. So it's serving all sorts of regulatory bodies, but I don't see any evidence of using the insights that comes from PALs and complaints and friends and family tests and all the other mechanisms of patient feedback that is available. And I just want to be reassured that it is also making use of that vast body of information and evidence, which often is much more helpful than a regulatory body's every now and then review.
Dawn.
Thank you. Through the CQRMs, the clinical quality risk meetings with the Trust, as with all providers, we do require as part of the quality schedule reports on patient experience, such as friends and family test, complaints and PALS feedback. We're provided with information on claims and complaints. So there is that information coming through. I think, I mean, I've been in post just over a year, and we've seen that quality of reporting certainly improve over the last year. But again, it comes back to the data, the ability to turn around data very quickly. So there has been an improvement. They do try and triangulate information from patient care, as we do when we receive the reports. And maybe at the next quality committee, Meredith, it may be something that the quality committee would like to have those specific reports, which wouldn't in bulk come to the quality committee in that way.
Okay, thank you. Thank you. John.
Yeah, thank you, Dawn. I think what you present here is a very clear timeline, but also a description of what I think is one of the considerable challenges, and that challenge is to how we are reassured about the safety of an organisation that provides services to our patients. And in your summary, you very clearly articulate the collective responsibility that exists in maintaining that assurance. You've detailed the current methods that are in place: the stay safe calls, serious incident analysis, the visits intended, planned and unplanned, to name but a few of the items within your report, at trying to gain an overall sight of safety, and that's well done. And we all, certainly as clinicians, have individual responsibilities in whichever organisation we're in, and collective responsibilities. What I think is at the particularly reassuring is that CQC are now heavily involved in this process, and they have considerable resources, teams, experience to pick out what is safe practice. And I know that they'll be particularly interested in that degree of safety in the here and now. So it's a feeling that, yes, we are using all the mechanisms that I can see that are available, but that assurance that there is an organisation who are particularly skilled in this area that are on the ground. It was that observation that I really wanted to put across.
Okay, thank you. Any further questions or comments? If not, I've got a couple of comments really. One is that at the heart of this obviously should be the patients and the quality of care that we're providing to those patients that our providers are giving and that is available in the local health economy. I think you're right to point out the vast majority of people attending SATH get a very a good level of service, a high quality level of service. I I think you're right to point out that all the staff are actually sort of working to their utmost to provide a high level of service, but I think we can't forget there are some patients where harm has happened to, and that we need to obviously look into these and not be afraid of asking difficult questions, really. And two questions that for me come to mind are, one about what appears on the face of it to be inconsistency between what we're getting at the daily safe call, which is where we ask, the safety day call, where we ask them about the competencies of staff, and actually the feedback from WMQRES that are saying they're not happy in their initial letter, which obviously SAF may challenge, but in their initial letter about the processes around checking competencies. And I wonder whether we should be actually writing to SAF to ask them to explain to us that difference, or whether you have any comments on that difference. The second one is a challenge back to SAF around, which I think will be covered by our SI review, because obviously you mentioned about the coroner's Section 28 report that came to the Trust around the care of a patient who unfortunately passed away, and there was issues there with sepsis and also staffing. Now that was 10 months ago, nearly a year ago, and so SAF would have had time to have done the SI, done the RCA and the SI, and come up with conclusions and put into place things to actually stop that happening again. Yet we do find the CQC going into SAF and finding exactly the same problem sort of 9 or 10 months after that incident has occurred. And I'm just wondering if I say that's one of the reasons we're having the SI review and looking to put in place the SI review, and that's supported by NHSE and NHSI, but wondering whether you had any immediate comments on that or further comments on those 2 points.
I think it would be very reasonable to write to the Trust following the West Midlands review and the paediatric assurances, because that was a specific request that we understood that the competencies of any staff, whether they're agency, locums or otherwise, were in place for both nursing and medical staff. So I think the West Midlands review obviously clearly identified that those competencies weren't in place. We are getting assurance on a daily basis now about the paediatric assurances, but yes, I think it would be reasonable to write formally on that. The issue with the Coroner Regulation 28, absolutely. We did receive the root cause analysis. It did advise that sepsis management was an issue. We were advised of the sepsis management plans and changes and training to staff. And yet, very sadly, clearly, issues are still being picked up by the CQC currently.
Okay. Thank you for that. Simon, do you want to draw this together for the moment before we move on to the A&E paper, which is obviously intimately related to this and the fallout from this?
Clearly it's been a difficult period for everybody involved. Our single focus during this period has been really to ensure that we are discharging our duty of care in respect of the safety of services that we commission. And I think the report does demonstrate that we have for many months now been expressing a level of concern around the management of patients, particularly, although not exclusively, within the A&E department. And I think the CQC inspections were very welcome, and we wait to see what comes out of that, because of course SAF will have the opportunity to respond. I'd just like to sort of pick up on Finola's perspective as well, is that we need to be supportive of SAF. If we need this hospital to be safe for every patient that goes in there, and our best way of doing that is to be a supportive, critical friend of SAF, which is what we are doing and will do to the best of our abilities, really.
Okay, thank you. Unless there's any further comments, we'll move on to Julie Davis, who's presenting the paper on the Princess Royal Emergency Department closure, and then we'll have further board questions.
Thank you, Julian. Obviously, as governing body members are aware, Shrewsbury and Telford Hospitals Trust Board took a decision on the 27th of September that due to unsustainable staffing levels, they thought they had to proceed with planning arrangements to close Princess Royal Emergency Department overnight. I've attached that board paper for governing body colleagues to scrutinise. But since then, we've obviously, the Trust are pulling together the detailed planning that will be required for the implementation of that decision. And I've shared as Appendix 2 the proposed governance arrangements and the working groups and the structure that the Trust intend to implement to go through that work. I've outlined, it's clear that the Trust see that the CCG is a key partner in the preparation for that implementation of that decision. So we're obviously involved in quite a number of the groups, but I was bringing this for governing body members to comment on the arrangements as they are set out by the Trust at the moment, the contribution and the membership of those groups and the relative representatives of the CCG. We still have to agree who our GP member will be for the Clinical Pathways group, which, as I've outlined, I think is absolutely the most pivotal project group within that, because without having the detailed pathways agreed, we're then not in a position to agree the impact of those pathways with neighbouring providers. Also the consequences of those changes for other providers, so the ambulance services, non-emergency patient transport, local authority colleagues, all of that is pinned on that clinical pathways work. So that's a really key group. I did also want to point out that the intention of the Trust at the moment is working towards the date of the middle of November, but that is subject to final sign-off by their Trust board, that they are assured that all pathways are agreed and that all partners are signed up to that and effectively ready for that closure to take place. I've also proposed that in terms of, because there are so many groups that are going to be working on this and the pace is quite intense and all of the groups are meeting weekly, that we take a weekly update through the CCG's executive team, but that ultimately an overarching paper will need to go to our quality committee that will outline the final quality impact assessments that are completed around all the individual pathways and use that as our means of the full and final assurance required to support that decision. And then ultimately we bring an update back to governing body to the November meeting.
Thank you very much. We start with William, then Keith, then Finola. And Dawn. William.
All right, thank you. Sorry, Chair. Given obviously the enormous amount of work that staff at SAF, members of the executive team will have to be carried out to plan the arrangements for the closure of the NE department, do we have any concerns that that amount of focus on there would shift focus from other areas where we have concerns within SAF, and therefore we may find other problems cropping up? I'm not sure there's any answer to that, but historically I think we've seen where focus has shifted from one area to another, then other problems have cropped up elsewhere.
Absolutely, and that's a concern that we share. We have, obviously, we're intimately involved with the Trust in terms of the capacity that they've got around this. We do have some concerns that staff are stretched. We've seen other usual operational meetings, for example, around the reduction of stranded patients. Those meetings haven't taken place for a few weeks. And we had an extraordinary A&E delivery group yesterday, and I was chairing that group in the absence of Claire Old, who's currently on leave. And we asked NHS Improvement if there was any additional support that could be drafted in to help the Trust from an operational management point of view. We've also been in in-depth discussions with our colleagues in NHS England, and they've identified some potential experienced resource that was involved in similar work at County Hospital in Staffordshire. So that's now in SAF's court to pursue that, to try and gain that extra capacity. I think it is a risk, but what we have to do is, that's why we have to be involved in these groups. We have to be assured that the quality of the information and the work that's coming through and being presented by those groups is of sufficient standard. And if we are aware of any ongoing capacity issues, then I think it's part of our responsibility to escalate that and look for to support the trust in gaining additional capacity.
Okay, I think before we go to Keith, Simon wants to add something.
I just, I think this is always confusing, I think, particularly, not least of which is me, but also for members of the public. Just so the public are aware, the decision has been taken that they're going to close PRH overnight as that is the safest option. But how that's going to work is now being worked out. So the exact ways in which patients will be managed as a result of that closure is not yet fully understood. That will need to be worked through, and then each of those pathways will need to be subject to a quality impact assessment to make sure that it's of a sufficient standard and safe before a final decision's made. I'm sure it's not always kind of obvious what's going on, and I just thought in this conversation that isn't absolutely transparently clear, and I just wanted to make sure it was clear to the public.
Okay, thank you. Keith?
Given some of the problems that have been outlined earlier about getting information from SAF and making sure it's all complete, if we get to the stage when you bring the next report at next month's governing body meeting and we're not satisfied we've got all the information to show that the arrangements are safe for how patients are going to be handled, what happens then? Would that stop that action, or would it be up to SAF to still decide whether they were going to go ahead?
The route for that will be through the Safety Assurance Committee that's being set up next week by NHSI. The first meeting of that is on Tuesday morning, and Julie and Dawn and I are standing members of that group.
So it would be that group's decision, not ours?
Well, I mean, I think we would, obviously, if we wouldn't expect to disagree with that group, would we? That would be unusual for us to disagree, but if we did disagree with the group, then we'd have to find a way of inputting that into that process.
And given the timescales, I don't think we could afford, if we weren't assured, we couldn't afford to wait for the November board meeting. That's what we have. That's why I've suggested that we seek that detailed assurance through the quality impact assessments as described by Simon through the quality committee at the end of October, because I think we've literally that's in kind of 2 weeks' time. We've got to make sure that we are that at any point we have a concern, we escalate it. We can't. I don't think we can wait until that we're asking them to make a decision and then say that there's an issue. I think that's why we've got to be involved in the individual groups. And at any point we think there's an issue, I think it's absolutely our responsibility to raise that at the time.
Thanks.
Thank you, Finola.
Yes, and sort of moving for a moment from being supportive to being a critical friend, I'm just struck by the timeline. I mean, it's so short, and what's left to do is so enormous in terms of quantity of work and detail that I'm not. I have concerns about that, and also for whoever is asked to be the clinical pathway clinician in terms of interrogating those pathways. I think if the onus was on one GP on the board, I think, personally I'd feel quite uncomfortable with that. I think if we do have doubts at times about the quality or level of data that comes out of SAF, and then we're trying to decide whether clinical pathways are safe, I think having that scrutiny for more than one clinician might be a good idea, and so we can sort of get a body of opinion rather than perhaps relying on one colleague. That might help us to ensure that we are giving it the correct level of scrutiny given the timeline.
Okay, thank you. Dawn, did you want to respond to that, and you've got a question? Or?
Well, it was clinical pathways I wanted to talk about, because I think from a quality impact assessment we absolutely need to see the revised clinical pathways, not just us as a CCG, but other stakeholders, other providers, particularly Welsh Ambulance and the Ambulance Trust, because of the massive impacts, particularly for paediatrics. We requested those formally at a meeting last week and were advised that they would be coming out to us particularly the paediatric one, by Friday. We've not received them. I have written formally to the medical director requesting again, because until we receive them, we cannot do proper quality impact assessments. And, you know, as Finola says, it isn't about one person doing them. This is about us all having a shared opportunity to really challenge these pathways and look at where the potential impacts are.
Okay, I've got a couple of points as well, but I've got a couple more people who want to make points as well. So Meredith and then Keith.
Thank you very much. My comments is about prioritisation, and just to kind of get out into the open the notion that, or to seek permission, I suppose, for those people involved in this extraordinarily high priority work need to be recognised. Specifically, the work that Julie's doing, and Dawn, and our clinical colleagues, Gail as well, all around the organisation. They also have other jobs that are also important, that if they don't do, they will also be under scrutiny and criticised for it not being done. I mean, I asked a question this morning, Simon, why information hadn't been provided. Actually, that information is important, but in the scheme of things, not so critical. So I think it's just useful to have a kind of a recognition that there is license to make this such a priority that other things must inevitably be put to one side that would normally be a priority. So I just kind of want to make that point explicit.
No, thank you for that. Thank you, Meredith. Keith.
I just wanted to reflect on what has been said, and I have to say I still feel sceptical that we would have enough information to have the assurance for a decision to be made that this is going to be safe for patients.
Thank you. I mean, I think if you look at the number of governance meetings, I mean, I think if that number of meetings can't come up with assurance, Lord only knows what we'll do. I think it comes down to what is the safest option as well, doesn't it? I mean, I've got a couple of points I want to make. One is that I'm very supportive of SAF, but you know they don't do things to help themselves. You know, they're not very quick with the timelines. You know, with the pathways, the timelines of the pathways. And I do find it difficult with the numbers we get from SAF really sometimes. I mean, if you read their board report here, they're talking about to be sustainable, needing. And I think doctors only come in and nurses only come in whole people, but 9, so they need 9 middle grades and 24 nurses. Yet. And then the board make a decision that clearly says that they think they've reached the end point in that process of trying to get staff from elsewhere. Yet within a week, they're advertising for staff saying they need 5 more doctors and 8 more nurses. And I do find sometimes that it would be it's like catching a bouncing ball sometimes. And I want to help them. I want to catch the ball for them, and want to help patients with and improve the quality and safety. And build on what we have, but it is difficult when it's so hard to actually know really what the numbers are. I mean, do you have any feeling where the number does lie? Is it because often we're measuring different things, and the argument would be, well, actually it's 23 nurses for this, but only 15 nurses for this, or 5 for this.
Myself and Simon were at a regional escalation meeting for urgent care last Friday, and we were the number clarified by the trust at that meeting was that what they'd said was there's an absolute minimum that they would require, and that number quoted to us was 5 middle grades and the 15 nurses, and it was felt that the rate determining element of that was the middle grade doctors, that actually the difficulty in recruiting nurses is because of the availability of the appropriate level of medical staff to run the department well, and not to put too much pressure and undue clinical pressure on the nursing staff. So that was the figure that was clarified for us, but equally I think everyone's been anxious that those numbers have felt a little bit of a moving feast. But that was the level articulated by the trust, that if it was possible to make that number available, then they, obviously then it would have to go back through their trust board to make that decision. But that was the level communicated to us.
My next question is, I think probably for Simon or Claire really. I mean, it does worry me on the days that I'm not in the CCG, and some of the worries I carry around in my head are about the quality of services for patients and the impact on patients. I also worry about if something does go wrong, the impact on a member of staff for what is in fact 99 times out of 100 is going to be a system failure, will end up on a personal impact on that member of staff, be there a doctor, nurse, porter, you know, someone working in the labs, and that does truly worry me as well. But the thing that's sort of on the days that I'm paid to worry about it worries me is the finances, and how do we see the finances playing out? We're in a challenged financial position. You know, there's going to be greater ambulance transport, and contractually, where do we stand? And in the real world, where do we stand on the finances?
So I think I'll ask Claire to come in a minute, but strictly, if a provider can't deliver a service that has been commissioned from it, the cost of taking those patients somewhere else falls to the provider. So the 1.7 million that's been quoted by SAF, by West Midlands Ambulance Service, would fall to the provider. But I think in when you've got something of this scale, I think inevitably the system will be asked to come together to understand how it finances that. And I know Claire's had. I'll pass over to Claire at this point.
Yeah, so the finance is always going to be a thorny issue, but I think it's worth making it clear that at this stage that conversation is absolutely not getting in the way of working out what's right to do. So in recent discussions with Neil Nisbet, the Director of Finance over at SAF, everything we focused on is about making sure that we do the modelling behind the courses of action that are being worked up, and we'll park that discussion about future funding for another day. I think it's also fair to say that discussion isn't going to be one that's internal to our system. It will absolutely involve colleagues from NHS England and NHS Improvement as well. I think from an individual CCG perspective, what we have done at this stage is made it clear that we don't have a pound sign and a value to attribute to this at the moment. But given our financial position, what we can say with certainty is that we don't have the flexibility in our position to accommodate whatever that cost impact might be if and when it comes. And I think that's the best line that we can take at the moment. We acknowledge that it's there. We acknowledge that a discussion is needed, but energies need to go into developing the model first, and then we'll have the discussions with the regulators and others about how we handle that as a system.
And that's, Julian, that's why I identify that under the risk, in terms of the risks around financial and clinical sustainability. I think it's important on both fronts. One is that although this decision has been taken by SAF as a result of the current unsustainability of the clinical workforce, we're going to need assurance that the proposal around the closure of PRH actually demonstrates an improvement in that clinical stability. And also we did identify this as any cost associated with this that then is deemed to be attributable to the CCG will absolutely, does have the ability to impact on our ability to achieve our control total, because as Claire said, we don't have any flexibility left. And I just think it was helpful, that's why I included it in that risk assessment, so that governing body members were fully aware of that. Okay.
Unless there's any other further comments from the board, I'll just go back through the two things that the actions required over the last two papers. I think for Dawn's paper 237, the actions are fairly simple, and we can agree to those. The governing body is asked to receive and discuss the report and note the updates and actions being taken. The governing body notes the delivery plan will be developed, and the governing body requests monthly updates to that delivery plan. So I'm happy with those. Moving on to Julie's paper, I think these may require a little bit more discussion from Simon. The first one is fairly clear. The note the context of the update and receive assurance that the CCG will be fully involved in the detailed planning of the overnight closure of the PRH. So there's obviously a challenge there around the number of meetings that we've been asked to attend. The second action was agree the proposed CCG representatives to respective project groups. I suggest we take that outside the board meeting and do that. The final one, I think, is something that Simon might need to clarify, and builds on Keith's point about how we're going to do it, to seek full and final assurance on the quality impact assessments of the implementation plans from the Quality Committee, and receive a final update on the overnight closure of PRH at the governing body meeting in November. So, what do you think about those two?
I think that we'll need to take that back through the NHSI meeting and come back on that.
On both these two.
Now, the proposed CCG
The second one
representative...
for Tottenham.
Sorry.
It's being fully involved. The question about how can we be fully involved with all the different competing pressures on times.
Well, I think... I know my good friend Jonathan has a view on this, that part of that Tuesday meeting is going to work through the rather labyrinthine governance structure that's been put in place and see if we can't get to a more sensible place at the moment, I think.
I think I'd agree that at this point of that clarity needs to come through that group. You're in unprecedented times around some of the governance. So I would go back through that group to say what actually would be coming here in that meeting in November if we're looking at those timelines.
So both actions 1 and 3 are subject to the Tuesday.
I think it's gaining that clarity from that meeting on Tuesday.
What's that meeting called? So I missed the.
It's called the... I don't know what it's called, but it's Tuesday morning at 10 o'clock.
Right.
Safety assurance.
Quality assurance.
It's called...
I think we've just done that bit.
SAT Safety Oversight Group.
Yeah.
Okay, so we'll use that same.
You'll have both regulators there, and again, they will need to be comfortable with these processes.
Okay. So thank you very much. What I propose to do now is we're running slightly ahead of time, is to actually, on these 2 papers, open the meeting up to questions from the floor about these 2 papers, the quality review update and the PRH emergency department closure. So if there's any questions, if you start with Mr. Bickerton. Sorry, there's a microphone for you, I think.
That's a meeting I went to with SAF. He said the closure of the A&E in Telford would cost them £3.5 million a year. So how's that money going to be made up? Because they're going to be paying that out of the county.
Yeah, we'll ask Claire just to comment about that. Obviously, that's in this paper here.
Yeah, so the trust receive a level of income through the contract that we have with them. What will happen if they don't provide the activity anymore, i.e. it goes out of county to Wolverhampton or somewhere else, then they don't get the income attributable to those patients. So they've done some calculations that say the impact of losing that income that's attached to the patients that have gone elsewhere, and they won't be able to remove all of the cost that they've got in the system, and that's the £3.5 million that's been quoted.
Okay. Thank you, Councillor Jones.
Thank you. Well, I'm glad that you've known for 2 years that patient care at SAF is unsafe. Do you think you should have told the public about this earlier? It seems to me, I'm afraid...
I think, as we said, that's why it's been well documented in our public board meetings that we've been flagging these concerns.
I'm a regular attender at board meetings, as you know, and apart from saying things like the A&E will fall over if we don't implement Future Fit, there has been very little real discussion and real concern about the safety of patients. And, I
don't think that's... I can't accept that, because that's not correct.
Well,
I mean, that's nice of you to have, but it's not what I...
I'm a reasonably well-informed patient and member of the public, and I found it... I can remember the shock at being at a joint HOSC meeting when there was a letter from Simon Wright saying that various services were unsafe, and it listed them. I think there were about 5, and there was nobody there from SAF to explain to the joint hospital. But I mean, so it came as quite a shock to me, and it certainly hadn't been part of a public discussion.
I'm sorry, I think you're talking about the Fragile Services report, and I don't believe it did say the services were unsafe. They said there was a level of fragility associated with the staffing. So I'm sorry, Sylvia, I do think language is important here. It is very important.
Language is important, and public debate is also very important.
Because it's not a public debate, this is a meeting in public. If you'd like to get your question...
What I'm getting at is that, that during the public consultation on Future Fit, this has not emerged as a possible, an area for discussion, and the public have been unaware. The public filling in the consultation forms have been unaware of the really serious state of patient services at SAF. And it would seem to me, as someone who's attended a lot of those meetings, that you have perhaps deliberately chosen not to discuss those
That's an
issues.
appalling allegation, but I'll let we'll finish your question. We'll let Simon answer your question. We're going to let Simon answer that part, the bit of the question around that.
It's just that what I would say is that here you are with Future Fit proposing to let a failing organisation run up debts of 312 million or more, when frankly I wouldn't trust them to actually organise our
Amazing
village
conflation
fete.
of lots of different issues, but I will let Simon answer the question.
So I think the service fragility of a number of services at SAF has been widely discussed at this board and widely viewed at the joint HOSC and individual HOSCs. I think the word safety is a difficult word, isn't it? So what we were saying, if you think with the fragility of the neurology service, for example, was that quite simply SAF didn't have enough consultants to see the patients. It wasn't that it wasn't safe, it was that the SAF service simply didn't have the capacity to deal with the input volume. So what we did there, and the board and the HOSC were very well cited on this, was that we agreed to move those patients out of county to a provider who could undertake the work. With A&E, we have been flagging for some time that we are concerned with potential impact on patient outcomes arising from the staffing situation at SAF, and that was subject to a risk review last year and this year, both of which were taken to board meetings, as I recall. I think it's very hard for us to declare that it is unsafe. What we are saying is, because that really is for the attendant clinicians at SAF to declare, what we've said in this instance is that we're seeing a number of apparently related SIs where potential harm may have come to patients, and where that SI has identified, the RCA of that SI has identified that staffing shortages may be an issue. So I think it is a very, and I do agree, I don't know who it was who said here, is it is safe for the majority of patients. Yeah, it's just on individual occasions where we see staffing shortages, and we have an SI, and we have, as a board, done everything we can, I think, to bring that to the fore.
Okay, thank you. We've got the question from
So
the lady.
can I just mention one other thing? Sorry, this has got absolutely nothing to do with Future Fit. Full stop.
Okay, thank you. We've got the lady. Thank you. The lady at the back. Sorry.
Oh yes. I think I'd have to challenge your last remark there. At the
So I
moment,
can't hear you.
I'll have to challenge your last remark that anything that this governing body is looking at has nothing to do with Future Fit. I think the integration through the STPs nationally brings together all of our healthcare sectors, and your particular STP does just that, and Future Fit is a part of that. So if I could make that response.
So we'll just
respond to that, because that just does not understand the question we've been asked is...
No, I understand the question.
The question we've been asked is the closure of PRH was known about during the consultation and not disclosed. That is absolutely not true, and there is no evidence. Well, we can all start conflating issues, Sylvia, as you've done to me. The issue of a provider to suspend a service because it's unsafe or not sustainable is an issue for the provider itself. It's got nothing to do with Future Fit at all. It's a completely separate process.
Excuse me, that was a general point I was making, which I think I'd like to have on record. And I'd like to pick up Keith's point about the responsibility of governing bodies. I don't think it was acceptably answered there. A governing body is ultimately responsible for the decisions made as individuals and collectively. So I think there are issues there around the governing body responsibility, which the member Keith picked up on. And secondly, I'd like to pick up on this sort of opacity of information. I don't dispute that within the thousands of pages of documents that all of your boards have produced, there is scattered around all of those, the information that Dawn, is it presented in her comprehensive commentary there. The difficulty for the public is that these are opaque. So they are not clear to the public. And I think, Julian, you made that point yourself. And just before I finish, can I check that we will have another chance to speak later?
These are just questions just about these two.
Yeah. Well,
Yes,
that's
yeah.
fine. Yeah, because I wanted to raise something
Sure. You can do,
entirely
yes.
differently. Thank
Yeah,
you.
definitely. Thank you for those comments. I think one of the reasons that we did this paper today was actually, and also we had the minutes from the last meeting, was actually to draw together a timeline to make it clearer to people what the CCG had done and the timings of that. So thank you for those comments. We've got the lady directly in front, the turquoise top.
I'm Joyce Stocks, and I'm talking on behalf of the Defender NHS. I've got a few questions about financial costs.
Sorry, could you speak a little more into the microphone? Sorry.
About financial costs. You're saying that there's going to be a loss of about 3.4 million in lost business as a result of closing PRH overnight, and assumes the CCGs will cover the cost of increased ambulance provision. Defender NHS has been advised by a senior doctor living locally that short-term staffing could be arranged between now and January for very much less money than this, and that by looking at overseas doctors from Greece and Commonwealth countries and also supporting middle grades into becoming consultants on a proactive basis, South could recruit those staff in the medium term. It would cost, but less than they want to spend on overnight closure. Longer-term recruitment depends on a change of culture and probably of SATH leadership.
Okay, should we answer that? Is that the first question? We'll answer each question one by one, if that's all right. If Simon wants to answer that.
So I think we are 100% with you. If SATH could get the staff to keep the A&E open, that is the best option. The board of SATH have made the decision that they can't. So I think that question should be to the SATH board. I can't comment on the likelihood of them being able to attract the staff. Well, they've clearly taken a decision they can't.
And obviously the SATH losing money doesn't save us money because we pay someone else because it's a tariff-based system. And we certainly haven't agreed that the ambulance costs, contractually the ambulance costs fall to SATH. All the costs of closing a service on the grounds of safety by the provider do fall to the provider through the NHS standard contract, though obviously, as I've said before, everything's a negotiation in life, especially between directors of finance. But I think these questions do need to go back to SATH. SATH have, through their board paper, detailed the steps they have taken to recruit staff, and obviously we've seen that publicly they're taking more steps now. I think it's fairly common knowledge there's jobs at SATH if you would want a job in A&E. But thank you for that. In front of your second question.
Right. The other ones are clinically, is the CCG confident that this is safe for patients? In particular, is its confidence that Stoke and Wolverhampton A&Es have the capacity for additional patients? Both are failing to meet the 4-hour A&E target, and both have significant numbers of patients facing long trolley waits before admission. And do you also know that Stoke and A&E recently diverted paediatric cases to Telford due to capacity issues?
I think it comes back to the issue that the current situation is clearly not safe, and what is the safest option. Wolverhampton Trust have said in meetings they have the capacity to see the patients in Wolverhampton, but not the capacity of doctors to send doctors to Shrewsbury to help. How trusts manage their workforce and their plans, but is up to those trusts, but they have been clear that it's within their winter plans to take into account the SATH activity that will come in their direction.
The final one is that are you confident about the safety of sick children in Shropshire under these arrangements? Jill, of course, lives in Ludlow, and one suggestion from SATH is that children will go to Shrewsbury A&E, which does not have paediatric specialists, or the specialists who can intubate a child who is struggling to breathe. Another suggestion is that those children will travel to Wolverhampton or Birmingham for care. We wait an hour for an ambulance in Ludlow, add a journey to Birmingham with a child with breathing difficulties. How is that safe?
So I think probably from slightly different perspectives, but your concerns about paediatrics are one of the concerns shared by the board, and this process that SAF are now going through would be to get to the point where I can answer that question. Yeah.
Thank you. So, further questions, or we can move on to Mr. Sandbach. Do you have a further question, or no? Thank you, David.
The county is in a very, very difficult position. I've never known it be in such a position, and I've lived in the county now for 40 years. I mean, what is happening is truly terrible. Some of the responsibility for that is yours. Some of the responsibility for that is SAT's. My question, Chairman, is would the officers and yourself support my idea, which you're well aware of, which is to have an urgent care centre, a facility at PRH as a means of preventing half the county having to seek urgent care outside of the county? Thank you, Chairman.
Certainly, I think you're right. There is a system responsibility and accountability, and that includes ourselves, it includes SAF, it includes NHSI, and it includes NHSE. I mean, I think if you look at one of the main reasons that Princess Royal couldn't work as the main base for A&E is that it only has one CT and one MRI. They're on the brink of breakdown and need urgent replacement, and that situation could have been avoided if that had been dealt with in a more timely fashion and a replacement programme had been in place. So I think there's lots of bits that all add up to get to the place where we are now. I think in terms of whether we'd support your plan, I think I'll let Simon answer that one.
So theoretically, it would be part of an answer, wouldn't it? But it doesn't, of course, deal with the out-of-county serious admissions that would happen. Where would they go? Because they clearly won't be seen in an urgent care centre. An urgent care centre, possibly part of the solution, but that's going to take time to work up and put in place, and staff, for example. So I would expect SAF to be or that group to be looking at all the potential mitigations. I'm sure one of those might be something like that. I've heard other suggestions, David, of elsewhere in the country whereby A&Es that have suffered pressures like this have closed at peak pressure times, but not at other times. So, for example, where they've got peak pressure due to staffing, they close, but the majority of the time they're open. So I think through this group, they'll be looking at every available opportunity to get the best possible answer for patients.
Can I just say, Chairman, peak pressure times in A&E actually occur between about 10 in the morning and around about 2 in the afternoon. That's when you get peak pressure, not after 8 a.m. Sorry,
8 p.m.
8 p.m.
Correct, yeah. Yes, but pressure is a combination of volume and capacity, isn't it?
Yeah.
It's not just a volume measure.
Well, what I'm picking up is a defeatist attitude, to be quite frank. You just want to run away. This meeting, there's a lot of backstabbing on SAF to start off with.
I think that's absolutely
Some of your comments are outrageous and they're completely unfounded. And to be honest, I'm just going to draw a line under it, and we can go and have our coffee break 10 minutes early. So if we have our break now, we'll restart again at 20 to 2. very much. We can take a seat so we can start again. Moving straight on to paper 239, which is Julie Davis and the commissioning intentions for 1920.
Thank you, Chair. Slight technical problem. This paper is brought to the governing body to outline the draft commissioning intentions that have been issued as part of our planning for the 2019-20 contract rounds for all our providers. It highlights the key intentions in the paper, and then obviously also provides as an appendix the summary of the letters that were sent to all our key providers. I wasn't intending to talk through it, but happy to take any questions on the specific elements within there.
No, thank you for that. Any questions about the commission intentions? Keith?
I realise that there's the West Midlands. I realise that there's a West Midlands contract for the ambulance service. Yes. There's nothing here that outlines what we're putting through as our contribution to that. We did discuss that at the previous meeting about what we would be doing. So have we got anything that you can share with the meeting today about what we expect for the contract round for the ambulance?
Yeah, we've got Gail.
I'll pick that up, Keith. So there's a number of pieces of work that are going on at an STP level with respect to commissioning of the ambulance service. So I'm picking up that role with for both CCGs at an STP level. So I'm directly going to be involved in developing our service specification for Shropshire, Telford and Wrekin, and the expectation around the commissioning intentions with WMAS through the regional commissioning team.
Thanks.
Any further questions? William?
Thank you, Chair. I had a couple of questions, if I may. On 2.3, the MSK triage and assessment service, we talk here about reducing the number of patients referred to secondary care to 23%. Just for sort of context, what's the current sort of level?
Absolutely. The plan for this year is 30%, and this is based on national benchmarking for when similar other schemes have worked elsewhere in the country. The sort of actually we've been quite prudent overall, because this isn't the total position, because there's another 10% that normally goes through our values-based commissioning policy that would go straight through. So in total it would be around a 33% from, if you take the percentage as a percentage of the actual GP referral demand, it would be 33%, where this year our target is currently 40%. But we've been very prudent. Elsewhere in the country, it's anywhere between sort of 16 to 20% after a couple of years of the conservative equivalent being in place. So we were prudent this year and went for the 40% total, the 10% through VBC and the 30% through the interface service, the Shropshire Orthopaedic Outreach Service, and we're just looking to bring that closer to the national benchmarking position for next year.
Okay, and the second question, if I had the on, if I may, 4.1. It's probably my ignorance on this point. The access rate. Yeah. There's a reference here to an extension of the MSK service, and I couldn't quite understand the link between the IAPT and the MSK.
Yeah. This is because obviously there is an intention to very much link the access to psychological therapies to individuals with long-term conditions, and obviously a number of long-term conditions can be musculoskeletal related, particularly chronic pain, etc. There has been an expansion of that on the Telford side of the county that's not been put in place yet for Shropshire. So we're very keen to see, and we're working with our colleagues in Telford to see how effective that is and what benefit that gives that. And then we're basically stating the intention that should that be proven to be good, then it's our intention to extend that across the county.
So it's a good example, really, of taking the services to the patients.
Absolutely, yeah.
Finola?
Thank you. As the Joint Clinical Lead for Shropshire Care Close to Home, I, of course, am particularly interested in the community contract, which obviously historically has been difficult to monitor in terms of the way it's set up. It looks a very ambitious plan to completely change that, actually. I mean, that's going to require a complete sort of change of culture and for all of us, but particularly the Trust. And it's an ambitious timeline to get that up and running. I'm delighted to see it there, but even at this stage, first of all, are we happy that, or do we anticipate the Community Trust having appetite and desire to do this? And secondly, who are we dealing with? Because obviously they've got to be absolutely cited on our commissioning intentions for the future of Shropshire's healthcare system.
So I'm not sure what do you mean by who's cited on this. This goes through to Shropcom.
Yes.
So exactly to their, it will go through ultimately to their head of
Shropcom
contracting, but is part of Ros Preen's
Okay,
directorate, which
fine.
will go through, and it should
Okay.
go through to exec level in the
Okay.
Trust, so they should be
Great.
absolutely
Yes, all over
cited on this.
because they're part of our working group.
And don't forget, within commissioning intentions, it's much better. It's our aspiration. It's for us to set what our aspirations are. If then, as part of our contractual negotiation, we have to, have some sort of, give and take with providers, that's absolutely fine. But it's our opportunity as a commissioning organisation to state what our sort of strategic intent and what our aspirations are for the following year. And then it's obviously subject to negotiation.
Great, okay, thank you.
Any other questions? If not, we can note the commissioning intentions for 1920, and we can move on. So thank you for that, Julie. Move on to your next paper, which is the 0 to 25 emotional health and wellbeing service.
Okay. Obviously, the purpose of this paper was to keep the governing body informed of the progress made as a result of the National Intensive Support Team visit to the Child and Adolescent Mental Health Service is now provided by Midlands Partnership Foundation Trust for us. And this is outlining the work that we've done across both CCGs and with Midlands Partnership Trust around the action plan to improve the children and adolescent mental health services. It identifies the 6 areas that we've prioritised for the action plan. It identifies that there's ongoing regular meetings with the Trust to progress these actions. It also identifies some improved governance and system-wide. One of the things that we were criticised by the intensive support team is across Shropshire and Telford we didn't have enough of a joined-up strategic view for children and adolescent mental health. So the intention is that part of it was we brought Steve Trenchard in to provide that support across the two and to bring all of this together, and he helped by writing this report. But we've obviously now trying to bring together the governance and the means by which we will deliver this. So we have a consistent view of what the challenges are and what the actions are required to put it right, but we also have a joint delivery group that we're going to use as oversight to make sure we deliver that. I think it's fair to say that at the moment we're still quite cautious about this, which is why we maintain our position around limited assurance, because although we've got the plan and we're starting to see improvements, we think there's significant challenges still to be overcome. And therefore we ask that we want to get on and continue that work at pace over the next 2 months and bring back a more detailed update. In the December meeting, the reason we said December was if we come back next time, it feels like maybe we haven't made that much progress. I believe that in 2 months' time we'll be able to come back with a significant improvement in the service that we can share with colleagues, and we'd be looking to increase that level of assurance over the next 2 to 3 months.
Thank you. Just a question whether I'm not sure we have a December board meeting, do we? I think it's...
Sorry,
December.
No, we won't be having a public board meeting.
No, it will be January.
Okay.
Questions from the board? William?
It's really some comments really in support, because I think, we're obviously at these governing body meetings, we've heard a number of real heartfelt stories about the experiences of members of the public and their families with the 0-25 service. And I think I watched a programme, I think it was on Panorama a few weeks ago, which really reinforced the consequences of a service that doesn't deliver in this area. And it really, personally, it really made me think that we've got to get this right for our patients and our public. And so it's good that we are making progress, and I fully endorse that we've got to see this as a priority, because it's, to me, I was thinking about this. You don't turn up at A&E with a broken leg and they say, well, we'll see you in 6 months' time to fix it. And that's really what's happening with mental health services sometimes. And that's, to me, seems not right.
Yeah.
Thank you. Deborah?
There were just two things, and I'll mention both of them, and I'll let you answer both of them. One was, perhaps, could you give us just a little bit more information about the legacy issues? And it's mentioned in the action plan, but exactly what they are and what they involve. And also in the action plan, under the service identity section, was partly addressing system-wide cultural changes required across primary care in understanding mental health for children and young people. Can you tell us a bit more about that, and what we as GPs can help with, or what you're wanting of us?
Yeah, I was hoping that Steve was going to be able to help with that, because of his clinical background, he'd be in a far better position to answer that than I would. Unfortunately, I think he's been delayed. First, in terms of the legacy issues, this is around the cohort of patients that effectively were inherited by the Foundation Trust from the original service that was provided by the Community Trust. We've all been aware for some time that model of care was quite outdated. It was a very medically driven model. It wasn't so much therapy driven as it could and should be now. And what we've got to do is, obviously, we've got a cohort. It's about 1,400 children and young people that were obviously subject to that old model, and it's how do we work that through. And as we are working towards the new pathways within the new service, how do we manage that cohort of patients and migrate them safely through, based on their individual needs, through to that less medicalised model. So that's really the work that's going to undertake. With regard to the cultural changes, my understanding of this is that, again, that's about, because historically because we've been used to a certain model of care for children and adolescents, then that's what our GPs expect, and that's how they are referring and accessing service and encouraging children and young people to access. Again, what this is about is to trying to look at the different methods, so making good use of the drop-in sessions, the online services, all of that to really change the way that we access. And hopefully, by using some of the online services and the drop-in, we're able to intercept some children and young people at an earlier stage in their mental health issues, and not let it progress to more serious levels. So I think it's about embracing that change in pathways and that new way of delivering services. And it's not just in how we deliver services for patients, it's also how we access and how we message that from primary care.
One of the things that seems to have gone backwards is the direct access to the single point of access. Well, one is having a single point of access. We now have two, don't we? And the other one is having direct access to it for families and for young adults. Yeah,
and that's definitely one of the things that we want to pick up as part of the, let me just find the right heading under the list. Under the very much around the sort of evidence-based pathways and the access, that's one of the key things that we want to do. It's almost, I see this as a bit of a parallel with what we've been trying to do with physiotherapy, and the fact that the whole self-referral, again, because of demand into services, because of a lot of the pressures and the issues that Midlands Partnership Foundation Trust found when they took over the service. It's taken time to resolve that. We are holding the trust very much to account, because if we're honest, we think they could have made more progress more quickly, but we have to acknowledge where we are and continue to drive them to improve that more quickly, and that in itself will then help us support and have the capacity within the services to improve the self-referral. The single point of access, I think, is something that I've particularly asked Steve to pick up on, because we know that was a fundamental part of what certainly this side of the county wanted as part of the new plan, and it doesn't, for a number of reasons, doesn't appear to have translated into the new model of care. So I've asked Steve as that to be one of the areas that we focus on to try and get that reinstated as part of the service that we always wanted to commission, but we're not quite where we wanted to be at the moment.
Okay, and what exactly are we putting on the governing body assurance framework?
Yes, this is because we are concerned about that legacy cohort of patients. We want to make sure that that's given the right priority. Both myself and Dawn believe that we think that's a level that certainly, because that's currently sitting on my directorate risk register, I feel that that's too high a level of risk for me to contain within my directorate, and therefore I'm recommending to the governing body that we put that on the board assurance framework, and that way then we can, it's visible, and we can make sure that we're making the progress that we need to and minimising that risk as quickly as possible.
Good, thank you. Was there any other points on the board? Dawn, did you?
Yes, I mean, it is referred to in the exception report, but I think it's important to note as well, from the quality point of view, we have been discussing this month on month at the governing body, and because of the legacy issues and some of the delays, perhaps the lack of pace, I did last week raise this as a serious incident for NHS England to be aware as well on our STICE reporting system.
Okay, thank you. Any further questions? If not, we're asked to note the 3 recommendations, to note the contents of the update and receive limited assurance about the progress, to move on to the governing body assurance framework, and to bring a review back to the January board meeting.
Apologies for that.
Thank you. Move on to a paper from Simon Freeman about, on behalf of Debbie Vogler, the proposed approach for the conscientious consideration of consultation findings and subsequent decision-making process.
Yeah, this is about Future Fit. So this is about how post-consultation we move towards a decision, really. So the paper just sets out broadly what those decision points are. So as the board are aware, the initial analysis of the consultation responses is being undertaken by an independent third party. That output will come into a joint board workshop with independent facilitation in mid-November 2018. And the output of that will be a formal report to the programme board, which will take place in late November 2018. Together with various documents that will constitute a decision-making business case, which will go to individual CCG board meetings and a programme board meeting in December 2018, and individual CCG board meetings January 2019, and a joint committee probably at the end of January 2019 would be the target date. What isn't in here is any considerations at the moment of requirements of the joint HOSC, or any consideration of any NHS England assurance requirements, which will come to light during the process. So I'm very happy to take any questions.
And just for clarification, the individual CCG board meeting in December would have to be, if it fits in with the time, would be an extraordinary board meeting just with that one item. Any questions or queries? No? If not, then we can note the next steps and decision-making process. Sorry, Meredith, sorry.
Thank you. I'm pretty sure I know the answer. In the paper, there's lots of references to stakeholders being involved. I just wanted to be confident that there was a systematic approach to ensuring patients and the public are part of that stakeholder community in the discussion and deliberation process.
So,
I'll have to come back to you on that. My expectation at the moment is all stakeholders, or all formal stakeholders, are represented at the programme board.
Okay, yeah, just a bit more detail would be useful. Thank you.
Thank you. Any further comments or questions? If not, we can note the report and move to the next item, which is Claire Skidmore with the financial report.
Thank you. So the figures presented here today are our month 5, our August position. We have overall very little movement in terms of what I'm reporting since the previous meetings. So at month 5 we were forecasting to still be achieving our control total and fully mitigating all of our risks. You've heard me talk previously about the challenges we've got in actually achieving that position, and once again I'm here talking to you about the fact that it's not getting any easier. It really is tough. What I will say is that the drivers of where we are deviating from plan aren't any different to what we've talked about previously. So we're still experiencing a level of overheating within our acute contracts that we're working hard to contain and manage. I'll come to the quick report as a separate item, but that is a contributory factor to the difficulties in the position. So we think we will have around 2.5 million slippage on our existing programme. But again, we're taking steps to try and claw that back where we can to try and stabilise the position. And as I've talked about previously, again, we've had some difficulties and challenges within our CHC position. A good amount of that is reflected through that quip that I've just talked about. But as you'll see in this paper, we are seeing a number of new high-cost cases. In particular, this month it's been children's cases, and that is part of our normal business as a CCG. So sometimes we do get high-cost individuals that we have to fund. That's not an issue in itself, but given our financial position and our lack of flexibility to respond to things like that, it really does make life quite difficult. That's probably all that I was going to highlight in terms of the finance report. I will pause there, and I'm happy to take questions at that point.
Questions got William, then Keith.
Thank you, Claire. Just really a question, looking at the sort of month 4 to month 5 movement and the sort of total expenditure, there's the sort of net, I think 1.4 million increase in the forecast outturn for the year, and you've obviously mentioned that continuing complex care is one of those areas. I'm just trying to reconcile in my own mind that at month 4 we were saying that we were effectively fully utilising our reserve position to meet the position at month 4, and yet we've got extra cost pressures at month 5, and yet we're still achieving the same outcome.
Yeah. So I think what we've got is presentational in some respects. Yeah. So we have a number of actions that the team are undertaking specifically around the areas that we've just talked about, and certainly helped by the additional resources that we've got in through the support agreement that we have. At the point that we consolidated the month 5 numbers, the anticipated impact of the benefit of those actions was loaded on one line in reserves, and what you'll see as we move through the months is that we'll be attributing that to where it will actually land in the position, if that makes sense. So as I say, it's symptomatic of that position that I talked about last month, I think, here, which is that we're working harder to stand still, and at the moment we can just about make things add up in terms of hitting that bottom line and our judgment around what we still have the ability to deliver between now and the end of the year. But I think that's the point that I'm making, really, that flexibility really is now stretched to a point where, you know, it will only take one more thing and we'll be unable to respond to it, really.
Thank you.
Keith.
Yeah, I agree the quit pressures are a real concern, particularly as we're so far into the year. We've got extra staff to try and help us deliver a lot of the key schemes. Yeah. But as we discussed at the Finance Committee last week, a lot of these schemes are still at the sort of planning stages, have yet to move to implementation. I think there has to be an acceptance at some stage that some of those are actually going to deliver mainly in the following year. Mm-hmm. So while it's still valuable work, it's not necessarily going to help bridge that £2.5 million gap you were talking about, and we just need to be clear as a governing body about the risk we're facing on that at the moment.
And I think that's why it's so important that we reflect that gap in the numbers, because you reach a point where, you know, your anticipated actions do become aspirational because your ability to physically deliver them in year is diminished just because of the time to actually get things moving.
Yeah.
Thank you. Any further questions on the finances? If not, we can note the contents of the report and move on to Claire's second report, which is on the QUIP schemes.
Thank you. So again, these are our month 5 figures, and as I've just mentioned, we've got about 2.5 million pounds worth of slippage. I tend to deliver lots of bad news stories, but I have to keep reminding myself sometimes, don't forget the 18 million that we are saying we're going to deliver. But you know, that's a lot of hard work that's gone into that. I think one of the key things that, particularly in terms of our reporting for Finance Committee this month that we've started to focus on, is exactly around that nervousness that we've just talked about under the other item, in terms of how much of what we think we'll deliver is now becoming back-ended, and what level of risk does that give to us with regard to actually physically delivering that and cashing it out of the position. I think that discussion at committee this month was particularly helpful for us as a team, because it gives me some confidence that we're giving the right assurances to the board around what we're doing, but it also helps in terms of the management team, from my point of view, making sure that people are sighted on the scale of the challenge and what we need to do about it. So the tone of this paper, you'll notice, is slightly different from previous papers, and this is us now developing our narrative to our committees and the governing body to be a lot more risk focused, really, because I think that's what's going to help us over the coming months in terms of managing the challenges that we've got. Again, probably nothing that I wanted to draw particular specific attention to, other than that point about that shift in terms of more risk focus, but I'm happy to take questions.
Keith?
Not a question, but just to reinforce your point, at the Finance Committee, there was a really useful discussion, a very long discussion about QUIP and where we were with the schemes, and particularly reliance on a lot of the work that Kevin's been leading on the QUIP programme board, which I think is much better interrelated now with the work of the Finance Committee. Our conclusion, I think, was that the processes for QUIP, we are much more positive about them, and see that we've got a much better prospect of delivering significant money, which, given we've got to deliver 99 million savings over 5 years, as you always remind us, Claire, it seems a huge figure. But I think what we are, as a committee, was we were still guarded about our ability to deliver that total this year, and that was the conclusion. So positive, as you outlined, but also still guarded about our ability to deliver.
Thank you. Any further questions or comments to go to the QUIP paper? No, if not, then we'll note that and move on to Julie Davis and the corporate performance report.
Thank you, Chair. I think so this is broadly in line with the report that I brought last month. As a CCG, we continue to have challenges around our cancer targets, IAPT, A&E, and RTT. What I would like to bring to the governing body's attention is that although we've had some challenges with our 2-week waits, particularly with our local provider, we have received assurance that the issues around the capacity with breast radiology and dermatology have been addressed. They have committed to seeing an improvement in the September-October timescales, and we expect to hold them to that. If there's obviously, because of the very two specific issues, at this point we've not felt the need to have a formal remedial action plan, but obviously if we get any indication over the next few weeks that there's in any danger of slipping, then obviously that will be reinforced more formally. Significantly though, our major challenges around our cancer performance and our 18 weeks remain out of county. And I have asked our contracting colleagues who are doing a piece of work to support us, because although we've been following due process and working with lead commissioners for out-of-county providers, we don't seem to be able to get the, I guess, the pace and the improvement in the out-of-county position that we expect. And unfortunately, the performance out of county is so low now that it will take us off as a CCG. So I just wanted to assure governing body, we've asked them to look at that and see if there's anything else that we can and could be doing to improve that, because that remains a significant risk. Of course, A&E remains a continued concern, and that's well versed in terms of conversations earlier. I believe that there's still significant challenge there, and we'll need what we haven't worked through yet with the trust, as well as also the priority has to be at the moment around, as we've talked earlier, the planned closure of Princess Royal overnight. As yet, we have not modelled through what any expected improvement in performance would be a part of that, because at the moment we're just purely focusing on making sure that we get the pathways and the patient elements of that worked through. I would have a note of caution though for governing body. Don't think that just because PRH may be closed and we know that performance deteriorates overnight, that equally will have some kind of silver bullet effect on our performance and will miraculously improve. It won't. I think we just need to be quite cautious about that and work that through. And again, I would hope to be able to bring at least an indicative view of that back to next month's governing body, because obviously by then we'll have worked up in much more detail that plan of closure, and we'll be able to model that through. So with that, happy to take any further questions.
Rod?
Thanks, Chair. Julie, it's really just to pick up any more detail associated with the IAPT figures for adults. Yep. I appreciate the earlier paper on children. Mm-hmm. What's that meaning for parents who are trying to access the service?
At the moment, what that means in terms of the issue around it is we're on a trajectory to improve that access target over the next few years. We had invested a sum of money with the Foundation Trust to increase that access target to 19% this year. There's a slight complication because all of that was done in good faith, but it was done on the basis, and I don't think it certainly wasn't clear to us at the time that was based on previous years' arrangements where Health Education England had kind of training places within that service. And that has been removed this year, and I don't think any of us, it's not just a problem in Shropshire, this is a national issue, that's then had the removal of that by Health Education England has meant that the training posts that would normally be helping to support that workforce and that increase access are not there. So what we're trying to work through, and we're working through with the Trust, is that we will get, and their recruitment in Q3 is expected, and so far, we've not heard anything else that gives us cause for concern. What that means is where we were hoping to have achieved the 19% access for the year end, what it's likely to mean is we'll only be at that run rate towards the end of the year, because the extra staff won't be in place until Q4. So that's really that's what's going to happen, is we're going to see a slight delay in the achievement of that and the phasing of that. But the intention is that by the year end, we will be at that 19% run rate.
Okay. Just a supplementary to that. In terms of the point 14 on your paper, where it's saying 97.3% of patients on a care pathway were followed up within 7 days against the 95% standard. Now that looks good, and I think part of the reason for me asking this question is that the government have made some statements around improving mental health and improving staffing in mental health, and there's a confidence issue for the public in terms of, if I have a mental health problem and I seek advice, how quickly will I get access to that service? When I try and look behind those figures, certainly for the adult side, it seems that Shropshire isn't doing that badly in comparison to other parts of the country. And I wanted to just check that, because that's an important message to the public about what confidence they can have if they're seeking advice about any type of mental health problem.
Yeah, I think comparatively, absolutely. However, I don't think we can afford to be complacent, because I think overall the position nationally is not good. And just so to be the top end of an overall position that's not where we'd want it to be isn't necessarily the right answer either. So I think absolutely, relatively and benchmark wise, we are performing well. I think there's room for improvement, and that's what we're obviously planning to do over our local transformation plans for mental health, not only for children and young people, but there's a significant emphasis on improved access to crisis services for adult mental health. I think that is probably our area where at the moment we are probably, I don't think we're quite able to, we are not, our provider is not giving the service that we would want for our population at this point, and that's our area of focus.
Thank you.
Finola?
Thank you. Julie, I think you've mentioned for a while that there's been issues with two-way referral to breast cancer, and it looks like the numbers now are starting to come through. Yeah. I mean, the 30% looks bad, but I appreciate that, and they quickly managed to recover back to 14 days. But what was the kind of longest wait? Because obviously in terms of numbers, it might not be that much, but it just looks bad from a percentage.
In terms of the longest wait that I was informed of was 27 days against the 14, but that was literally only over a sort of a couple of day period before they got extra capacity. And so although I think that was the maximum wait that certainly was reported to me, but they fairly quickly, as I say, they've been operating back down to the 14 days by the end of August. Again, we're making sure that the trust is the first to admit that is still quite fragile, because they are out to advert for the substantive radiologist post, and again that's another area that's not just a challenge locally in terms of clinical workforce, but that is being supported with locum staff at the moment. So there is back to our earlier comment, there is a fragility around that, but that does not mean to say that there's any issue with the service. There is capacity there to meet the needs of our population.
Thank you. Any further questions? If not, we're asked to note the contents of the report. So thank you, Julie. Thank you. Yours is the next report as well, the elective care waiting time management.
Okay. This is the second month that we've brought the new report as a requirement from our regulator colleagues to ensure that we're maintaining I guess an equal balance in our focus, as well as urgent care and A&E, but also on planned care. As I said, I'm pleased to report that at the moment, in terms of the assurance around us maintaining our levels of planned care waiting list at or below the level of March 2018, we to date have got a slight reduction on that position, so we're looking good on that. The majority of that will be seen across our two main providers, but as I alluded to earlier, our overall performance is absolutely impacted by out of area, and here it's quite stark in terms of where we know Shrewsbury and Telford are achieving and have consistently achieved the 92% throughout the year, where we've got performance of 70% at Wye Valley, even though it's a relatively small number of patients. That's so low that it is enough to knock us off overall at a CCG level. We continue to ensure that our GP practices are made aware of the long waits in these providers, and again through our referral assessment service we continue to ensure that patients are made aware of that and the alternatives are available. But we do, we are frustrated that we're not seeing the level of improvement there as quickly as we would want. Likewise, in terms of 52-week waits, again we've had a number. I'm pleased to report that although we had a figure of 11 at the end of July, that has come down considerably. I think it was 8 at the end of August, and we believe again that number's on quite a rapid reduction in terms of that trajectory. But again, we still have some concerns around some data quality issues with Wye Valley in terms of the figures that we've been reported, so we're addressing that. They are currently in a formal dispute with their host commissioner, but we're continuing to work with them to improve that for our patients.
Julie, do we know if in Wye Valley they offer the sort of what they have to under the sort of NHS Constitution and the statutory rights about offering alternative providers?
We, for any patient that's waiting over 52 weeks to assure governing body colleagues, although obviously we're not privy to the patient identifiable information, we do know sort of the numbers at an individual trust level. We know exactly how long a patient has been waiting, and we see on a weekly basis we get information from all providers of our long waits. We seek information in terms of we ask whether they have a treatment date and that's been booked. We also seek assurance that where that treatment has not been offered within 52 weeks, that provider has followed due process and offered that patient choice, and we're able to report back that that choice has been offered and whether or not the patient has chosen to take up that alternative. So we have that status weekly, and actually we report that weekly up through NHS England.
Okay, thank you. Any other questions from the board, or any questions from the board? No, thank you. Then we'll note the contents of that report and move on to Dawn Clark and the quality exception report.
Are we doing the contract?
Sorry, the contract forward report. I missed out that exciting bit. Gail.
Thank you, Chair. I think the report is in a similar vein to the one that was received last month. This is obviously reporting month 4 activity, and as you'll see from Claire's report, month 5 has shifted slightly in certainly from SAT's position. Points to note for SAT, I mean across all of the main contracts and acute, it's about 2% above plan. For SAT, it's largely driven, overperformance is largely driven, as we've heard, by A&E attendance and emergency activity. There is a slight increase in elective activity, but that is not as material as we've seen with respect to the emergency activity. With respect to Robert Jones and Agnes Hunt, we have a activity query notice open with them around the referral to treatment times, because that's significantly an outlier for us. With respect to our out of county contracts, as Julie's just mentioned, with a significant increase in spend with Wye Valley and Betsy Cadwallader, which the teams are looking at to try and understand what's happening there with respect to that planning and the assumptions that we originally set the contract on. With respect to the mental health partnership, we've heard that there remains a contract performance notice with respect to the 0 to 25 service, and also there's an activity query notice with respect to overperformance against the non-admitted patient activity, which is a significant change from what we saw last year with respect to this contract. Just moving on then to the Shropshire doctors out of hours contract. I think it's fair to say that this is the July data of the first 5 indicators are related in part to the Care UK, and what I'd propose is that from next month we split that out so that we can see the difference between what we've commissioned from Care UK and the impact on the GP out of hours. So at face value it would seem that the impact of the change and the move to Care UK hasn't had a significant impact, certainly in the first month of the service. In terms of moving on to the non-emergency patient transport, this is slightly above plan, and we've issued there's a contract performance notice that's been issued in relation to some of the key performance indicators, but none of these are ever singularly causal. So the team's working with the commissioning team and the trust and the provider to understand how we can improve that for delivery of those KPIs. And finally, as we've heard, the ambulance service, we've got a significant overperformance, which I'm picking up directly with the regional commissioner.
Okay, thank you. Questions on the contracting report? Keith?
The West Midlands Ambulance Activity Query Notice has been live for quite some time. I'm struggling to understand quite why it takes so long to get an answer. Do you know why it's taking so long?
No, and that's one of my main my first question to the regional commissioners. I mean, I don't think we've perhaps asked the right question, and again, I'm not entirely sure that we've asked the right question, and B, we've been sufficiently visible and made ourselves present to get the answers that we require. I think when you look at commissioning at a larger level at scale, there's winners and losers, and in the big cities like Birmingham, you get that economies of scale across the patch. But for us, we need something different in Shropshire, and I think that's what we need to be driving for now as part of our economy. The urgent and emergency services.
Thanks.
Thank you. Any further questions on that report? If not, we'll note the contents of the report, and this time we'll definitely move on to the quality protection report.
Thank you, Chair. Obviously, we've talked at length about the SAF issues today, so I'm not going to go into anything further, only to say about the information technology software system failures that have been reported in the last 3 or 4 months, and Julie referred earlier to some of the work going on there. And we do know that action plans are in place to address any governance issues internally about contacting patients, etc. Robert Jones and Agnes Hunt, we've reported previously the information sharing, the information governance breach. We have had confirmation back from the Trust that the Information Commissioner's Office has confirmed that no further action is taken, so they're satisfied with the action taken by the Trust. We will be reviewing the final RCA at our Serious Incident Committee this month before formally closing that. We've reported previously issues about staffing in Bishop's Castle Community Hospital, and we had a further concern raised. We've had written assurance by the Trust Senior Executive Team that recruitment is underway for a replacement ward manager, and in the interim the locality clinical manager is based on the ward with other senior support. But there have been historic difficulties recruiting there, but they are assured that the staffing roster in place provides safe care for patients. I believe, Finola, you attended Bishop's Castle recently with regard to sepsis management. I don't know if you want to say anything at this stage on that. No. Not you, I beg pardon, it was somebody else, but I believe that a meeting took place to look at sepsis management, and assurance was given that the proper processes are in place. Mentioned earlier about the MPFT OT25 service. You'll recall the audit that was undertaken and presented 2 or 3 months ago at board. MPFT were to be providing us with an action plan. Unfortunately, the person that David Cohn worked with at the time has left. The work hadn't been handed over, and that's being followed up now, but it will be included within the ESIS report. Mentioned the serious incident reported, and what I should have mentioned earlier was that MPFT executive team are aware that we reported this incident through, as are Telford as lead commissioner, and I have spoken with CQC about the issues as well, as it will be discussed at the quality surveillance group that NHS England hold later in the month. So it's a fairly short report this month, but I'm very happy to take any questions.
Thank you for that. Questions from the board? Keith.
The outpatient computer problem at SAT's a concern, because 3 years ago we had exactly the same situation in ophthalmology, and we were assured by SAT that they would take an action to make sure that that didn't happen again. I don't know the details, but if it is exactly the same problem, it's worrying that something where they said they'd taken action is still causing issues.
I would agree, Keith, and I think that's the reason for bringing it here and drawing attention, because this is obviously a recurring theme, and I think we do need to consider if the work that Julie's doing, if there's anything else in addition to that we need to do.
Thanks.
Thank you. Any further questions? No, if not, we'll...
Julian, can I say that's Keith, that's why we triangulated it with what was on the Shrewsbury and Telford Board risk register around IT, because that's what we were concerned about, that it accurately reflected the concerns that we have, and that's what we're just working that through with them at the moment.
Yeah, thanks.
If there's no further questions, we can note the content of the report and we can move on to the Governing Body Assurance Framework.
Okay, the Governing Body Assurance Framework for the period up to the end of September is presented to the Governing Body for consideration. You will note from looking at the detail of the GBAF that there are a number of risk items where progress around mitigating those risks is evident. However, there are some elements on the framework that reflect some of the risks highlighted in terms of some of the system issues that we've been discussing today, which may need further consideration from the governing body. In particular, the governing body is asked to review the position around risk item 11, the impact of sustainability of local out-of-hours provider, in terms of development of this risk and replacement of that risk in terms of the current situation. The governing body is also asked to reflect on the risks noted within the framework that relate to some of the issues that we've been discussing today, in particular around the closure of PRH, and the 0 to 25 service, and whether they need to be noted on the GBAF in a slightly different way, given some of those discussions. So I think those are the main issues I want to highlight today.
Thank you. Questions with regard to the GBAF? In terms of reflecting the concerns we've got around SAF and the closure of PRH-ED, whereabouts is that? Where can we see those up-to-date changes in the GBAF?
The changes each time are noted in red, so you'll see that particularly on item 2, quality and safety, and then the item relating to workforce, which I think is number 7. I mean, it is a thread really throughout the GBAF, so you may well consider that item 3 is also relevant in this regard.
Yeah. And then obviously we're adding to it the risks we've discussed today about the CAMs. That will come on to the next.
So there's I think there's a request to the board to consider adding that as an additional risk. Although I think Julie has noted that this has been covered within her Directorate Risk Register, she's now making the suggestion to the governing body to consider that being escalated onto the Governing Body Assurance Framework, given the level of concern.
Okay. Dawn.
Yeah, I second that, because we've got it on our Quality Risk Register as well, and I think we need to escalate.
Any further comments or questions about the Governing Body Assurance Framework? No? If not, thank you, Sam. We'll note that. And then we'll move on to the workforce report.
You're going out of workforce, that's fine.
That's sure.
Just bear with me while I shuffle my papers around and get the right one. So the workforce report that's been presented to the governing body as part of the papers for today focuses on workforce matters within our CCG as an organisation. You'll see from looking at the detail of the report, the figures contained within it and the tables, that the CCG is presenting a relatively stable position in terms of its staffing for the period from April 2018 to date. You will note in the report some areas that are rated as red against the CSU standard target. I think we, as is demonstrated in the report, there are sufficient ways of explaining why those ratings are red over that particular period. In particular, we know that we've had high levels of turnover in terms of staff. And as a result of that, and in addition to that, we have employed a number of short-term staff to assist us with particular programmes of work, and also to fill gaps in staffing, which plays into these figures. We're also aware of a number of planned long-term episodes of sickness, which are also reflected in the figures here. I've also noted the position around mandatory training, and for those of you who are regular attenders at our staff briefings, you'll know that this is a bit of a mantra of mine at the moment. We haven't met our target, which is 100%. I don't think that should detract from the fact that there has been a huge amount of work with staff to get to the position that's reflected in this report. We did move to a new online system back in September, and that was a sort of line in the sand in terms of mandatory training, everybody starting again and going through all their training to get that up to date. So although it's disappointing that we haven't met the target, and clearly we need to address that and work with staff to impress upon them the importance of this, there has been a significant amount of work taking that forward, and I think the view would be that the system that we're running at the moment is a significant improvement on the previous one. I think those are the main points that I wanted to raise in terms of the statistics in the report. I would just like to note that we are running a staff survey which opens today for a month to ensure that we give staff an opportunity to give anonymous feedback to us in terms of how it feels to work in the organisation, improvements that we might be able to make for staff, etc. So we'll be reporting the results of that back to the governing body in due course. It will also be a significant factor in developing and moulding our organisational development strategy in the future, and I hope to be bringing that back to the governing body early in the new financial year. And I'm sure there'll be members around the table who will be keen to input into the development of that as that goes forward. Any questions?
Julie?
I haven't got a question, but something I think maybe I'm just unlucky, but on the on our training system, because Sam was very helpfully chasing me because I hadn't done my conflict of interest training, which I've now completed. But when I actually went on there and you look at your sort of My Learning, it kind of gives you a summary of you know what you've done, and it's meant to identify your gaps and the bits that you need to do, and it doesn't do that. It didn't come up and tell me. So if I think there's a problem because staff are going on there. If you just look at My Learning, well, it didn't on mine. I hadn't identified, so I think we need to just work through that because that might be
It's not really a governing body discussion.
No, what I meant was it's a reason that we need to explore, because that might be why staff think they are doing better on their training than they are. So it's something we should look at to improve our delivery of the target.
Okay, no, thank you. Rod?
Thanks, Chair. Though this report focuses on the CCG, and our position is relatively good in comparison to other parts of the health and social care economy, there is a theme that's emerging for us in terms of recruitment and retention of staff across the whole of the health and social care economy. Today the CQC's State of Care report is highlighting the huge number of vacancies that there are across the country. And we've got an issue here where, thanks to a range of things that we've discussed about already, Shropshire's not necessarily seen as a good place to come and work. So there's an element, I think, for the CCG with its partners about what can we do that would make a difference to try and improve the recruitment and retention of staff, and in consequence improve the quality of care that we're providing for the patients in the population. And so I'm not looking for a detailed discussion here, but I would be recommending that with our various partners we get a good picture of what the vacancy situation is across the whole of the county, and look collectively at what we might be able to do to make a difference. In part because I know the local authority is looking at this issue about affordable housing for key workers and others within its part of the county. Thanks.
No, I would endorse that view. I think through the STP there is a workforce working group that's looking how partners can work together to actually showcase the attractions and the appeals of coming to work in Shropshire, which obviously is the best place to come and live and work. Although I have a bit of bias there. Any further comments or reflections on the workforce, Keith?
You're proposing that we have an annual report on this. I just wondered if people have got an appetite for having this quarterly, so we could look at trends on particularly things like vacancies and sick leave.
Sam, do you have a view on that?
Sounds good to me.
Yeah.
I'm delighted.
Excellent. So we'll move to make this a quarterly update to the board on the workforce. That'll be good. Thank you for that, Keith. Any further questions, and then we move on? Deborah?
It was just a quick question. I mean, working in the CCG regularly, I see how hard people are working, and I'm aware that meeting all the major challenges that we've got is a really difficulty for the limited workforce. I know we had the additional members of staff that came through. Is it the ISA funding to help us meet our control total? And I wanted to know whether we have fulfilled all those positions, but also really importantly, is that something that's going to be recurrent? Are those people permanent, or is it just for this year? So what do we do next year? Because these challenges aren't going to go away.
I think if you manage to stay alive till next year, then we'll face it then, yeah.
I think it's an important point though. So part of what the exec team will be doing probably December, January time is doing that stock take really in terms of what do we need for the 12 months ahead. So we have those resource discussions and we're developing those debates through the QUIP programme board, and we've just upped that to a weekly basis because it's an absolute killer question. We can have all the best ideas in the world for fantastic change, but if we don't have pairs of hands on the ground with the right skills to do it, then we're never going to achieve it. So I think on a day-to-day basis we kind of do that as we go, but certainly that stock take in sort of end of Q3, beginning of Q4 is going to be essential for us really to see how we future-proof what we're doing.
Thank you. Meredith.
Thank you very much. Yeah, just very quickly, the lay members put forward a number of suggestions, ideas, recommendations that might be helpful in terms of supporting and developing staff within the organisation. Just wanted to make sure, Sam, that those ideas were being built into your developments around this whole area of work.
Absolutely. The organisational development group will be chaired by Sarah. So I'm sure she will make sure that all of those points are fed into that work and are embedded within it.
Thank you.
Okay, thank you. Any further questions or comments? If not, we'll note the contents of the report and we'll also move to make this a quarterly report to the board. Thank you very much. And Sam, the next paper is for yours. It's the governing body member indemnity, which is...
Yes, fairly straightforward. Nothing particular to note on this other than the contents of the report are fairly self-explanatory, really reaffirming the position around governing body member indemnity and what that entails. Happy to take any questions, but really this paper was just about reaffirming that position for members.
Thank you. Any questions from board members? No, otherwise we'll note and support the CC stated position on the indemnity of its governing body members. Then we move on to the first Health Watch Shropshire report from Rachel. Alan.
Thank you. On the assumption that everybody has read the report, obviously it is quite a short report for the first one. As many of you know, I've been doing a handover throughout September and into October with Jane Randall-Smith, so I've been having a comprehensive overview of everything, and again I've seen a lot of colleagues around the room in meetings just to appraise myself of what's going on. So I'm not going to go through the whole report, but just pick out a couple of the things that from the discussions today we'll sort of go through, especially the next hot topic that we're doing, which is children and young people and mental health. from obviously the timeline that you're looking at reporting back, Julie, coming into January, I think by then we'll have some feedback. We're getting a lot of comments already for this, so we'll be able to do some analysis to support the feedback and everything that's coming through. So I think that's important moving forward. And the other thing is, one of the feedback things we're doing is with A&E, where we've got a meeting with Ruth Smith to look at how we're going to do some proactive feedback regarding A&E post-discharge. So we're working that through as to how that will work for Healthwatch and how we can then give some feedback as to the service that people are feeling that they're getting. Other key things, obviously, we've been continuing to do our engagement and we've been continuing to do our interim view. We're about to publish our accessible information standards for GPs on our website, so again, that will be coming soon. And I think it's important to just say, if we can promote the feedback and the comments through to Healthwatch, and I think one of the things that I'm keen to do over the next couple of months is look at how we can give some teeth to get that feedback proactively, as well as the comments that are coming through readily, so that we can give some feedback to the groups as to what people are saying. Happy
Thanks
to
very
take
much.
questions.
Thank you for that report and that update. Questions for Rachel? Julie.
Just to comment, say I really thank you for your offer of support around the 0 to 25. We'll make sure we pick that up. And I'd also, your ophthalmology issues that you'd identified, we do have a regular task and finish group with Shrewsbury and Telford hospitals on ophthalmology, so we'll make sure we feed that back through that group. So thank you for that.
Feed it in to our next parish council meeting.
It will certainly be in the minutes from the meeting if that's in time for your next parish council meeting.
I don't think it is, no. Okay, well, what I'll do is I'll try and remember what you've said.
So I'm quite happy to, we'll get a set of words.
A set of words would be helpful.
Yeah.
Yeah.
The next question I have is me, David Sandbach, and it's really easy. The Royal College of Obs and Gynae undertook a review of maternity services at the Trust in July 2017.
Yeah.
One of their recommendations concerned anaesthetic cover on the labour ward. As a result of your quality assurance inspections, has this matter now been resolved? In other words, is there still a problem with anaesthetic cover on the labour ward?
Dawn,
Yes, thank you, David. We did actually raise this with the Trust when the Royal College of Gynaecologists report came to the CQRM, because it was the one issue that didn't seem to have been resolved. We were given assurance on the day that because of the circumstances and other processes they had in place with clinicians, that the risk was managed. However, the Directorate Manager was in discussion with the anaesthetists and the Trust about making sure that those Royal College recommendations were met. I wasn't at the Royal CQRM last week because I was on leave, but I would expect it to be included as an update within that.
Yeah. One of the things that concerns me is, of course, this was in fact raised at a SAF board meeting. If I may, I'll just refer to the record. Consultant anaesthetic cover of the labour ward in accordance with the 2013 OAA/AA-GBI guidelines requires investment and is on the care group risk register. Now, that was said not very long ago, and that implies to me that nothing's been done. I'm not particularly happy about ladies going into labour and not being properly covered medically. I think that's wrong. And if we look at it, there's been more than a year passed since this was raised, and it needs to be sorted, and sorted very quickly.
I think it is being sorted, and she missed the last CQRM.
Been on the CQRM, I haven't caught up with the...
But you don't know whether they've got somebody.
No.
Which is interesting because, of course, Mr. Wright is giving out quite large these days that he's having no problems recruiting consultants. Thank you, Chairman.
Thank you. Thank you very much for that. We'll draw the meeting to a close. The next meeting is on Wednesday, the 14th of November, at a time and venue to be confirmed. I've had no other business notified to me.